In continuation of Egyptian Society of Nephrology, Continuous Nephrology Education Series, today the topic is acute kidney injury. I start with Part A, definitions, classifications, risk factors, and diagnosis of acute kidney injury. Firstly, AKI can be broadly defined as the rapid deterioration of renal functions resulting in the accumulation of nitrogenous wastes such as urea and creatinine. There are two classification schema for acute kidney injury, rifle classification and acute kidney injury network classification. Regarding rifle classification, it is abbreviation of risk, injury, failure, loss, and end-stage kidney disease. If you look to this slide, this classification schema depends upon the GFR criteria and urine output criteria. So if you have the patient with basal creatinine, for example, 1 milligram per deciliter, and you find it 1.5, this means increasing 1.5 fold, or glomerular filtration rate decreases by more than 25%, this is a stage of risk based on GFR criteria. Regarding urine output criteria, if the patient's body weight is 60 kilogram and for 6 hours the urine volume is less than 180 milli per minute, this means below 0.5 milli per kg per hour for 6 hours, this is a stage of risk. And then the stage of injury, creatinine increases by twofold, or GFR decreases by 50%, or the urine output through 12 hours is below 0.5 milli per kg per hour for 12 hours. And then stage of failure, increases serum creatinine by 3 folds, GFR decreases by 75%, or serum creatinine above 4 milligram per deciliter, or urine output decreases below 0.3 milli per kg per hour for 24 hours, or anuria for 12 hours. And then a stage of loss and a stage of end-stage kidney disease if this stage extends beyond 3 months. So 3 months is the cutoff point between acute kidney injury and end-stage kidney disease. If we are sticking to the upper rows, we'll be highly sensitive in diagnosis of acute kidney injury. But if we are sticking to the lower rows, we will be more specific. So this slide showed the application of rifle classification in sepsis and septic shock. So when the patients are admitted to the hospital with sepsis or septic shock, and then you follow them by rifle to categorize them into patients with no acute kidney injury, or patients with risk or injury or failure, and then you follow them while they are admitted in the hospital or intensive care unit, and you will find them evoluted from the stage to higher stage. So if you start with the admission rifle, you will find approximately 29% of the patients have no acute kidney injury, but the maximum rifle, the patients with no acute kidney injury dropped to 14%. So with the admission, there is evolution toward the higher stages of acute kidney injury, and it is linked with a poor outcome. So and this is the slide that showed the mortality. Mortality is coincidental and associated with higher stage. So the higher stage of rifle and the advanced stage of acute kidney injury, the higher the percentage of mortality. The second classification is acute kidney injury network classification. It is more simpler because it included 3 stages only: risk, injury, and failure. It depends on creatinine criteria and urine output criteria. So if creatinine increases by just 0.3 milligram per deciliter, this is a stage of risk, and or if creatinine increases by 1.5 fold, this is a stage of risk also. Injury, creatinine increases by 200% or 2-fold increase, or below 3 or and below 300% than baseline, or creatinine increases by 300% than baseline, or increase above 4 milligram per deciliter, this stage of failure. And then you can follow the urine output like the rifle criteria. So if urine output below 0.5 milli per kg per hour for 6 hours, the stage of risk, and vice versa, and etc. Application of the AKIN criteria to patients with critical illness in the ICU revealed that there is association between the staging of acute kidney injury and the mortality. So if we classify the patient based on creatinine, you may have the patient with no acute kidney injury, patients with stage 1, 2, and 3, as you see here, based on creatinine. The higher the stages of acute kidney injury, the higher the mortality and the lower survival of these patients. And again, if you classify the patients according to urine output, even the more the oligoria the patient has, the more the mortality and the lower the survival the patient will have. So we may classify the patient according to creatinine. So we have AKIN, acute kidney injury staging based on creatinine, or AKIN acute kidney injury stages based on urine output. Basing the classification on urine output is more impressive on the outcome of the patient. So the teaching point from this slide is that when the patient is admitted to intensive care unit by critical illness, we should follow the urine output hour by hour. It is very essential, and it reflects on the patient outcome. If there is any comparison between rifle and the AKIN criteria, this is the cross-tabulation showed that all these patients have acute kidney injury staging by rifle classification, and at the same moment they have no acute kidney injury based on the AKIN criteria. The other patient in this square have acute kidney injury network by the acute kidney injury by AKIN criteria, but no acute kidney injury based on rifle classification. Taking all things together, this means that the use of rifle system resulted in a higher detection rate of acute kidney injury during the first 48 hours of ICU stay. The other important point is the transient acute kidney injury. If the acute kidney injury occurs for short time period, then does it affect the patient's survival? The answer is yes. If you look here, if the patient is admitted for the first time with established acute necrosis, will find mortality 29%. If no acute kidney injury, mortality is 4.4%. And if there is transient acute kidney injury, the mortality is 14.8%. So it lies between patient with no acute kidney injury and patient with established acute necrosis. And if the patient is readmitted with transient acute kidney injury, you'll find even the mortality increased from 14 to 17%. So I want to highlight the importance of following the urine output and creatinine, and even the occurrence of acute kidney injury for a short period of time. It is very important because it's associated with patient death. Regarding the KDIGO guidelines of this year, for simplification, they defined the acute kidney injury as any of the following, and this classification is not graded: increased creatinine by more than 0.3 milligram per deciliter within 48 hours, or increased serum creatinine to above or equal 1.5 times baseline, which is known or presumed to have occurred within the prior 7 days, or urine volume below 0.5 milli per kg per hour for 6 hours. So this is a simple definition. And this is a simple staging based on the post stages of rifle and AKIN criteria taken together. You can read stage 1, 2, and 3 based on creatinine and urine output criteria. So stage 1, creatinine is 1.5 to 1.9 time baseline, or increasing by more or less 0.3 milligram per deciliter. And stage 2, creatinine between 2 to 2.9 time baseline. Stage 3, 3 times baseline creatinine, or increasing serum creatinine to above or equal 4 milligram per deciliter, or the patient situation is stated initiation of renal replacement therapy, or in patients below 18 years and decrease estimated GFR to below 35 milli per minute per 1.7 square meter surface area. This is based on the serum creatinine. And you can classify and staging acute kidney injury based on urine output. So if urine output is below 0.5 milli per kg per hour for 6 to 12 hours, stage 1. If it is below 0.5 milli per kg per hour for more than 12 hours, stage 2. If it is below 0.3 milli per kg per hour for 24 hours, this is stage 3. Or anuria for more than or equal 12 hours, this is stage 3 also. The cause of acute kidney injury should be determined whenever possible, and this is very important because whenever we know the cause, we can describe the best treatment for the cause of the acute kidney injury. The second sector of this presentation is the risk factor, and I think the job of physician is changed from just prescribing medicine to stratify the risk of the patients into low risk, moderate risk, or high risk for any disease. Regarding acute kidney injury, risk factor is defined as a situation that put the patient in the higher risk of the occurrence of acute kidney injury and not necessarily the occurrence of acute kidney injury. And these risk factors are classified into patient-related factors and iatrogenic factors. Patient-related factors include pre-existing renal dysfunction, so patients with baseline chronic kidney disease are more liable to any insult, so they are more liable to acute kidney injury. Patient with sepsis, because there is a close temporal relationship between sepsis and acute kidney injury. The majority of sepsis patients with sepsis have acute kidney injury, and the majority of acute kidney injury patients have sepsis. So sepsis and acute kidney injury behaves like twin. Old age, because in old age there is decrease in the capacity and in the reserve of the kidney, glomerulosclerosis, arteriosclerosis, so the kidney is more vulnerable to any insult or any etiology of acute kidney injury. Diabetes, hepatic failure, atherosclerosis, chronic hypertension, preoperative cardiac dysfunction, hypercalcemia, or stenosis, all these characteristics put the patient in risk for acute kidney injury. Regarding iatrogenic causes includes medications and procedures. Regarding medication, non-steroidal anti-inflammatory drug, this class of anti-inflammatory drug we don't like in nephrology because its harm is well evidenced in many studies. So we don't like non-steroidal anti-inflammatory drug. And whenever prescribed, I just remembered the recommendations extrapolated from the NephroSap issue of renal pharmacology. Whenever it is indicated and it's necessary, give the patient 1 tablet of non-steroidal per week, or paracetamol 500 milligram once per day, because even paracetamol is not without renal hazards. The other class, cyclooxygenase 2 inhibitor, it is nephrotoxic like cyclooxygenase 1 inhibitor. The question is angiotensin converting enzyme inhibitor or angiotensin receptor blocker classes of antihypertension, are they nephroprotective or nephrotoxic? The answer of this question, they are nephroprotective in general classification, but to be nephroprotective, we should apply them with the standard of care. The standard of care is that when we want to prescribe this inhibitor or angiotensin receptor blocker, we should have serum creatinine, and we should repeat serum creatinine within a week. And if there is any rise of creatinine, we should repeat it after another 1 week until reaching the plateau. And we shouldn't allow the increase of creatinine to exceed 0.3 or 30% of the baseline creatinine. If the increasing of creatinine exceeds 30% of baseline creatinine, we should stop them, because in this scenario they will be nephrotoxic. Other drugs like the contrast, and I think we covered it in the previous recording. Regarding the procedures, includes cardiopulmonary bypass procedures, surgery involving aortic clamp, increasing intra-abdominal pressure, and I'll discuss it in a case later on. Large arterial catheter replacement with risk of atherosclerosis, liver transplantation, and kidney transplantation. So this table summarizes all the patient and iatrogenic factors that increase the risk of acute kidney injury. The hyperuricemia is a risk factor for acute and chronic kidney disease. And regarding the KDIGO guidelines, they recommended that patients be stratified for risk of acute kidney injury according to their susceptibilities and exposures, and to manage patients according to their susceptibilities and exposure to reduce the risk of acute kidney injury, and test the patients at increased risk of acute kidney injury with measurement of serum creatinine and urine output to detect acute kidney injury, and individualize frequency and duration of monitoring based on patient risk and the clinical course. These are the KDIGO Guidelines. And this table summarizes exposures and susceptibilities. So you can find in exposures sepsis, critical illness, circulatory shock, burns, trauma, cardiac surgery, major non-cardiac surgery, nephrotoxic drug, radiocontrast agents, and the poisonous plants and animals. And the susceptibilities include dehydration, advanced age, female gender, black race, chronic kidney disease, chronic diseases like chronic heart, lung, or liver disease, diabetes mellitus, cancer, and anemia. This is another representation of risk factors in the form of exposure and susceptibilities. The causes of acute kidney injury may be prerenal factors, and the prerenal, what I mean by prerenal is that there is defect in the blood volume entering the kidney. So the defect either in circulation or the renal and the afferent artery. So there is decrease of the kidney perfusion. So these are the prerenal factors. And in prerenal acute kidney injury, usually we find the structure of the kidney is normal. Renal means that the defect inside the kidney, either in tubulo-interstitial or in the vascular component of the kidney or the glomerular component. So you can find rapid progressive glomerulonephritis, acute necrosis, acute interstitial nephritis, or vasculitis. All of these factors can lead to renal causes of acute kidney injury. Post-renal etiology means that defective excretion of the urine from the kidney and obstruction of the ureter or the uretrovesicle. The next sector is how to diagnose acute kidney injury. So it depends on history, examination, investigation, laboratory markers, and radiological investigations, and even biopsy. So history and the manifestation of the cause, the patient may be oliguric or non-oliguric. The patient may present with edema or hypertension and may have nausea, vomiting, or other uremic symptoms, and may present with complications. One of the most important respected complication is the hyperkalemia, because hyperkalemia can disturb the cardiac rhythm in the form of increasing the amplitude of the wave, decreasing EP wave, and even reaching sine wave and cardiac arrest in severe hyperkalemia. So we shouldn't leave the patient with hyperkalemia, and the hyperkalemia should be aggressively managed in patients with acute kidney injury. Sometimes symptoms carry the clue for the etiology. Suppose that the patient presents fever, arthralgia, and rashes. We should put into consideration the differential diagnosis of a small vessel vasculitis, like Wagner granulomatosis, microscopic cholangitis, systemic lupus erythematosus, anti-GBM disease. And if the patient presents with hemoptysis, this may be a clue for small cell vasculitis, anti-GBM disease. If the patient presents with hemolysis and thrombocytopenia, this may be a clue for hemolytic uremic syndrome. If the patient presents with hypercalcemia, hyperuricemia, bone pain, lytic lesion, this may be a clue for multiple myeloma. If the patient is supposed to receive vascular intervention and presents with renal failure, this may be a clue for cholesterol implied syndrome or atherosclerotic renal disease. If the patient presents with rising serum creatinine and rising CPK to higher values like 10,000, this is the clue for the rhabdomyolysis. One of the important points is that early nephrologist referral is very important, and the early nephrologist involvement in patient with acute kidney injury may reduce the risk of a further decrease in kidney function. Ultrasound is an important step in the diagnosis, and I don't consider renal ultrasound as an investigation. It is an examination because the kidney is usually non-palpable, so the examination of the kidney is by ultrasound. And whenever I request ultrasound or I do it by myself or doing it by myself, I should report on the kidney size, echogenicity, differentiation between the cortex and the medulla, and the presence or absence of hydronephrosis or back pressure. These are the 4 components that I am seeking to know from the ultrasound. So in this example, this is a kidney, normal kidney, and this is the diameter, the length of the longitudinal diameter, and this is the cortex and the medulla, and this is the wide strands here that are the fat in the pelvis. So this is the normal architecture of sonographic appearance of the kidney. Here, if you look here, this is distension of the pelvis, so this mild back pressure, and the back pressure means distension of the pelvis by urine, and urine has its black appearance in the ultrasound. And this is the more and more moderate back pressure with delineation of calyces but preservation still of the parenchyma. And this is the end stage of obstructive kidney that ends in a balloon dilatation with atrophy of the parenchyma. And we should exhaust ourselves that our patients don't reach this stage of neglected obstructive uropathy. Regarding urine examination is considered the liquid biopsy of the kidney. And I just remember from the early medical school that in the Hutchinson textbook of clinical examination, there was a quotation that the ghost of dead body blames the physician, why you don't examine my urine? Because if the urine is examined, the doctor may find red cell that may be the clue for the renal cell carcinoma. So applying urine examination in acute kidney injury, we look at the urine analysis. You may have nothing in the urine analysis, and this may be renal failure, or you may have red cell cast, this is glomerulonephritis, white cell cast or eosinophils, this is acute tubular interstitial nephritis. So the urine analysis can give even the clue for the cause of renal failure. Another scoring system put in consideration the low power examination for the presence of granular cast and the high power examination for the presence of renal tubular epithelial cell. And if either the cast or the cell is 0, this is 0 point. If it's between 1 to 5, this is 1 point. If it's exceeding 5, this means above or equal 6 is score 2. If we submit the renal tubular epithelial cell plus granular cells and it exceeds 3, this carries a poor outcome. If you look here to the slide, this is renal tubular epithelial cells, and these are the granular cast in this urine examination. Another important point, even if we have urine analysis with dipstick, just 1 plus proteinuria, this may increase the risk of acute kidney injury, and this was reported from a 1 million patient paper from Lancet that the presence of even 1 plus protein increases the risk of acute kidney injury by 2.5 folds. One of the important steps in the diagnosis is to differentiate between volume responsive acute kidney injury, the old name was pre-renal acute renal failure, and volume unresponsive acute kidney injury or established acute tubular necrosis. And this, we can discriminate between these two types of acute kidney injury by following the urinary indices or renal indices. So one of important indices is calculating or estimating blood urine nitrogen in the blood and serum creatinine, and dividing the blood urine nitrogen by serum creatinine. If it exceeds 20, this is with the volume responsive because the hydration increases reabsorption of blood urine nitrogen. The question is, what about urinary sodium? In pre-renal acute kidney injury, as I mentioned before, this means that renal tubules are healthy. So in response to the hydration, the kidney tubule absorb sodium to conserve sodium. So you'll find the sodium in urine is low, and the fractional excretion of sodium is below 1%. So urinary sodium is low in pre-renal and high in established acute tubular necrosis. This equation showed how we calculate the fractional excretion of sodium by multiplying urinary sodium multiplied by serum creatinine and divided by plasma sodium multiplied by urinary creatinine percentage. And if you find it below 1, this indicates an intact tubular function. If it's above 1, indicates euvolemia or tubular dysfunction, acute tubular necrosis. When we have a patient with acute kidney injury in the hospital, we should follow him thoroughly and serially. And the serial follow-up of creatinine, whenever we find the creatinine increases, this means the index hospitalization. And the higher the creatinine in the hospital, the more the adjusted hazard risk of mortality. So the higher the creatinine was followed up, the higher the risk of mortality the patient will have. There are many score indices like integral risk scoring in acute kidney injury, many variables, and each variable takes its score point, and calculating the point, the higher the score the patient has, the higher the risk of mortality. Even using isotope scan in animal model, they discriminate between acute interstitial nephritis, acute tubular necrosis, or the control by the distribution of isotope within the rat kidney. Regarding renal biopsy is indicated whenever the etiology is not well known. So if from the history and clinical examination, urine examination, it is clear it is pre-renal or established acute tubular necrosis, we will not do biopsy immediately. But if we have urine with indices of red cell cast, white cell cast biopsies indicated to categorize the kidney insult. If the cause is unknown, this is another indication. If the history is prolonged, so if acute tubular necrosis doesn't recover within 2 weeks or 1 month, biopsy is indicated in this situation. If we consider this is a normal biopsy, and this is from the net, you will find here the tubules are back to back with delicate interstitium between the tubules. But this from up to date, you can find here the acute tubular necrosis in full-blown picture. As you see, the slide showed focal loss of tubular epithelial cells as evidenced by these arrows, and the debris and even the cells are slaved within the lumen. So this is established acute tubular necrosis. The most prone structures for acute tubular necrosis in the kidney is the proximal tubule S3 segment and the medullary thick ascending limb only because of high metabolism in this component of the kidney. If the patient is treated with antibiotics and then creatinine increases and the patient presents with fever and eosinophilia, or even without that, and you can find some white cell cast or white cells in the urine, this is an indication of biopsy, and you can find a lot of interstitial inflammatory cell as evidence in this biopsy. So this biopsy is the biopsy of acute interstitial nephritis. And whenever we diagnose acute interstitial nephritis, a short course of steroid may be indicated that increase the recovery of acute interstitial nephritis. If the patient presents with recurrent episodes of macroscopic hematuria or microscopic hematuria, and the biopsy is indicated, you can find mesangial expansion, mesangial proliferation, mesangial deposition of IgA, so this is IgA nephropathy. And another case scenario is if the patient has repeated sore throat, and after a period of time, the patient presents with hematuria and renal serum creatinine with hypertension, and the biopsy reveal, as you see here, proliferations plus starry sky appearance of the IgG deposition in the kidney and subepithelial hump in electron microscopy. So this is a case of post-infectious glomerulonephritis, acute post-infectious glomerulonephritis. This is a very important slide because it shows the cast in the kidney tubules. This is the hematoxylin and eosin stained specimen, and this is BAS stained. The discrimination here, the casts are more pale with BAS stain, and this is a characteristic of the monoclonal cast, and this may refer to multiple myeloma, and the immunofluorescence for the kappa and the lambda revealed positive kappa. So this is a case of myeloma cast and nephropathy, kappa light chain disease. Another etiology of acute kidney injury is IgG4-related tubular interstitial nephritis, and IgG4 is present in many diseases involving the pancreas and others, and treatment is by steroids. And this is the typical biopsy showing the IgG4-related tubular interstitial nephritis with storiform. This is the appearance of fibrosis in comparison to the non-IgG4 interstitial nephritis. And again, another characteristic is extension of inflammatory cells to renal capsule. By this, I'll end the first part of the presentation of acute kidney injury, and thank you for attention.